All right, welcome, good afternoon, everyone entering into the virtual meeting room. We'll give everyone a few minutes and then we'll get underway. Take a look here. Some nice friends on the phone. Some great champions on the phone this afternoon. Excellent. Just looking at the lineup here. Wow, awesome. Just looking at the names. You know, in the beginning, I was able to say hello to each of you. And now we've grown to the point where there's simply too many of you to say hello to independently. Wow, this is great. All right. I've got a couple minutes after the hour, so we're going to go ahead and get started, knowing that people are filing in. Welcome to our Citizen CPR Foundation Monthly Champions webinar. On behalf of the foundation and myself, as well as our esteemed guests, I thank you and welcome you. Really appreciate your taking the time out of your very busy days to talk about the public health issue of sudden cardiac arrest. So welcome everyone. So glad that you could make it. All right, let's see if the gods of technology will embrace us. I did not get any announcements from any of you in advance. So I will simply make one announcement of our own, and that, you know, hey, December 2021, we're going to be meeting in San Diego for the next Cardiac Arrest Survival Summit. I believe the first day of the conference is December 7th, and look for more information regarding our second Cardiac Arrest Survival Summit in the near future. For those of you on the call who have local things happening, webinars, conferences, and the likes, please pre-communicate with me before our next webinar, and I'll be happy to make an announcement regarding your events. So, as you all know, for the repeat offenders on the call, we try to have some really stimulating conversation on these monthly webinars. We try to bring in some exciting guests every month. And this month, I have to say that I am absolutely delighted to have not only some extraordinarily talented individuals on the call, but two of the most delightful people that I know. Dr. Mickey Eisenberg and Ann Dahl, and we're going to speak to the subject of challenges in implementation, accountability, and leadership in out-of-hospital cardiac arrest this afternoon. You know, kudos to the Resuscitation Academy for another fabulous publication and resource for the resuscitation community. And this is the art and science of resuscitation. So, Ann Dahl, I'm going to pick on you first. I'm going to ask that you tell us a little bit about this new publication from the Academy, and why was the project undertaken, and, you know, how is this different from the other awesome resources that have been developed by the Academy? What audience is this best suited for?
Right on. Well, thanks, David. Thanks for having us. It's so much fun to look at the list of names of people and I think you're all our friends, whether or not I've met you or not. I know you're our friends. So, and a special konnichiwa to Chika, who's listening in from Japan. I think she's in Japan at the moment. So that's amazing. I don't know what time it is there, but it's early. I know that. So the art and science of resuscitation really is Mickey's brainchild. And so Mickey, I'll give my view on it, but then you can fill in kind of the color commentary of how it came to be, because I think this publication has been in the works for Mickey for quite some time. I mean, even probably at the same time or before the 10 steps was published. If you're not familiar with the 10 steps to improve cardiac arrest survival, that's available on the RA website, as is this publication. But I really see this as a foundational document to the work we do and the work we try to inspire, which is to inspire communities like yours to improve resuscitation. So it's seen as very much as foundational. This publication focuses in primarily on TCPR, HPCPR, rapid dispatch, and early defibrillation. And what the goal of the document is to summarize our philosophies on those 4 programs, and then really to give the reader a good grounding in the science behind our recommendations. We pull in performance standards to help give folks a very concrete goal to strive for. And we don't go into that level of detail in the 10 steps. So really, if you think like of the 10 steps, well, you can go way back. You can think of Mickey's first book, which is on the history of resuscitation, A Life in the Balance, available on Amazon.com. So if you consider, we've got the history, and then we've got the 10 programs to improve cardiac arrest survival as the next layer in the foundation. And then this goes even deeper because you're digging into the science, you're digging into the performance metrics that are associated with those 4 programs. And then I think the audience is anyone who's serious about trying to improve their community's response to cardiac arrest. So we traditionally think of that group as being EMS leaders, we at the RA, but I think that this is part of the good work that's a Citizen CPR Foundation, and it's really engaging everyone who's interested in improving cardiac arrest survival. I'm talking about elected officials, I'm talking about community activists, survivors, and it's giving those people the data in hand that they need to help build their teams of champions.
Well stated, right? It's, it takes a community. It takes a system to save a life, right?
Yeah, that's what we say.
I think we've heard that before. And I love the idea of having Mickey chime in as well. And Mickey, I have to say that I really appreciate the title. And the two of you know me, so like I honed right in on art, right? Art and science of resuscitation, and that, medicine, do I dare say, is still an evolving art, right? So I'd like for you to expand on what Anne has begun and talk about how this will be kind of evergreen, or at least we hope it will be, and how it might complement, the release of reaffirming or new guidelines from ILCOR and the independent resuscitation councils.
Well, thanks, David. It's really a pleasure seeing not only you, but Anne, and knowing all the people on the call. So hello, everyone. Yes, this has really been a journey for us in the Resuscitation Academy. When we first began, we thought, well, what can be easier? You just show these programs that work, and people will just take them home, and bingo, their resuscitation rates will just skyrocket. Well, life's a little more complicated than that. And it wasn't a matter of just learning about the program and making it happen. You needed to learn about leadership, implementation, accountability, that those were just as important as the actual steps in the program. And we learned that well from Peter Kudenchuk, one of our star faculty. He gives a talk on the science behind resuscitation, and everybody loves that talk. It's just clearly the best talk in the Resuscitation Academy. And then we would realize by following communities that had attended the academy that really change was very difficult. And so we realized that we needed something as gripping as his talk to talk about the actual implementation of programs. So that's what the art and science of resuscitation is all about. Now, to answer your question, ILCOR is coming out with new recommendations, and that's great. I anticipate seeing them. They're kept very secret, so I have no inside information on what they will be. But I think there will be nothing dramatically different in them. That's my prediction. I think it will essentially be tweaking the recommendations that exist now, but I think it will essentially be very similar to what we have, which makes the point that having those recommendations out there to implement, how do you make it happen? How do you make it happen in your community? And that's really the challenge all of us face.
Excellent. Excellent. You know, it's often I refer to it as, you know, the guideline to implementation gap, right? As I've said on previous champion calls, and perhaps, you know, in sidebar conversations with some of the participants, it's like, you know, you attend a great academic presentation. I'll pick on people on the right coast where I live, you know. I'll be at an academic institution in Boston and hear this fabulous talk, and at the end I'll say to myself, how can we know so much and not be very good at saving lives, right? So it appears that there's this like art component where we have to take this kind of these guidelines and put it through a translational process so that we can actually implement it in every community, whether it be, you know, an urban center, suburban, or a rural community. And I think, you know, change is difficult, and that's where the, you know, the devil's in the details, and where, you know, a good dose of art can do a great deal to help the science along. So interestingly, you know, and the book, the publication, I mean, it is kind of a book. It's like 70 pages. I printed it recently. My wife scolded me for doing so. But this new publication is really incredibly rich with, you know, high quality content. But, you know, of course, and it's probably no surprise to the two of you, but I gravitated right to chapter 8, which talks about, you know, the critical issues of challenges and implementation. Would you mind taking a moment to talk about the importance of chapter 8?
Sure. Chapter 8, improvement is possible. You know, this is really the piece where the rubber hits the road, where the Resuscitation Academy, you know, we feel like we have a good grip on the science, but we don't know what really goes on in your EMS system, in your community, because we don't live there and we're not in it. We have an idea, but we really don't. So the first big grain of salt that we put with all of this is that, you know, as we like to say, if you've seen one EMS system, you've seen one EMS system. And the more that we engage in this activity, the more we learn about what's happening in systems, you know, outside of our own. And but there are some truisms that really shine through, and we kind of lay out a plan forward that we think is a good plan for starting out. So, you know, one thing just to recognize is that the most important thing for communities is to take the first step. So we talk a little bit about the importance of overcoming that inertia of how things have done in the past to take the first step. We talk about building, you know, a community and surrounding yourself with like champions, like friends who can help you along the way. That's what we're here to do at the RA, and I know the Citizen CPR Foundation is as well. You know, and then after that, we get into some ideas around first steps for measuring and improving your system and on a programmatic level. So there's measuring your cardiac arrest data, but then it's finding out how your community is how they've built out the programs that we believe make a difference. Do you do telephone CPR? Yes or no? And if you say yes, then we need for a community to be able to back it up and to say that we have a protocol in place. We do regular training. We provide feedback on that training, and we share the results of the data. So we have a tool on our website that helps communities go through those programs and evaluate themselves, and then generate a targeted report for where they can best invest their efforts. We talk about the importance of a pilot. So anything that you're going to do, any new program that you might be considering starting, to start small. Give yourself a bite-sized piece to work with so that you can work through the maybe any kinks in the system, collect feedback on how an initial program has started, and then give yourself permission to blow the whole thing up, change different components, or move ahead. So it's things like that this chapter 8 kind of delves into on a deeper detail.
Yeah, well stated, and I appreciate your remarks. You know, it's really interesting when we talk about the challenges and, you know, accountability and things of that nature, but yet the community, it seems in many cases, the community isn't even really aware of what the situation is, right? I mean, we call 911 and the ambulance comes, you know, help comes. And some might even say that, you know, we've perhaps poisoned the pond a little bit with, you know, well, all I need to do is call 911, right? I mean, we have an ambulance service. What more is there to be done? They tell us that they save lives. I mean, really, what more is there to this whole story? So, you know, I again, I appreciate your details. Now I'm going to come back to Mickey now, and I'm going to call on you, Mickey, to talk about what the publication calls, you know, the challenge of accountability, right? If you could, tell us how we can best define accountability, right, in the context of sudden cardiac arrest, and why is it so challenging, and how can we collectively best address?
Thanks, David. The enemy of accountability is its diffusion, and that's unfortunately the case, that everybody is accountable for a system, and yet in a way nobody is accountable for a system. It's just spread out in this amorphous way, and who's going to take charge and be responsible for it. And I, of course, have no easy answers to any of this. There's accountability at the micro level and accountability at the macro level. And certainly at the macro level, it's the chief, it's the director, it's the medical director. You know, somebody with a title before their name: Director of Emergency Medical Services, Medical Director, and so on and so forth. That would be a logical place to start with accountability. But if you think about it, there's little steps that lead all the way down to the EMT responding to the scene, and the citizens, for that matter, who have to be accountable to what to do when somebody collapses. But certainly having a start, it would seem to me logical that the chief, the medical director, the EMS director, those would be the logical people to try to make change. Now, that level of responsibility, of course, goes up. There's mayors, there's county executives, but it also goes down. There's all the ranks within that organization. But if you were to pick a logical place to begin, it should be the EMS director, the chief of the organization, or the medical director. Those are the logical people to say, hey, I'm accountable, and I'm gonna learn what I need to do to make things better. That's a great starting point.
Yeah, yeah, that's really interesting, right? Accountability, because I had some ideas when I was thinking about how we were going to discuss this today with our audience. But then as I started thinking of it, I mean, accountability is defined really by who you are, right? And if we look at sudden cardiac arrest as a public health issue, which I truly believe it is, I can contrast it very easily against COVID, right? It's like, so we all have a certain degree of accountability. We have, and again, depending on where you are, defines that accountability. But myself as a citizen of the world, I feel as though I have an accountability, in regards to COVID, and that, I wear a mask so that I am protecting others as well as myself. And so accountability really not only speaks to like ownership of the program or the issue, which has been an ongoing challenge, right? Like, who owns this? Is it the EMS agency? Is it the fire service? Is it public health? Is it, where does this go? But ownership really seems to be something that's lacking.
David,
So I appreciate your remarks about accountability. Would you add anything else, Mickey?
yeah, let me just expand a tad. Ultimately, an organization is accountable to the community it serves, the people within that community. And if an organization is truly being accountable to the taxpayers, the people within that community, the response area, etc., they should be able to tell that community how they're performing. What is the cardiac arrest survival rate? Now, I know that's like a radical concept. You mean we're gonna share with the people that live in our town how many people we save from cardiac arrest? Wow, what a radical idea. And yet that is the ultimate accountability. It's the people you serve. If you're not telling them how well you are or are not serving them, then there's a problem in that community. So I'm going to get off my soapbox real soon, David.
Fascinating.
But
Fascinating, right?
Yeah.
Because you hear the life-saving message when, ambulance service seeks X amount of dollars to buy life-saving equipment, right? Or to help them save lives or to save more lives. And, I've had this conversation again with probably multiple parties on the call this afternoon, but it's like, like any good paramedic, when I first met my wife, when she was a complete stranger, she asked what I did. And I said, well, I saved lives. It's a good thing she didn't ask for a report card because she may not have opted to marry me, right? And so, perfect segue coming to you, Anne, is that, this whole notion of, a publicly available report card, increasing numbers of communities are now creating and sharing annual reports. Have you seen any excellent examples that you might consider best practices for others? And if so, why are they best, excellent examples? And good God, is there a downside to this whole thing?
And Mickey, you can kick the soapbox over to me now. So I'll hop up on my soapbox. So and spoiler alert, everybody, David helped us out. And so we knew what the questions were going to be so that we could prepare.
Yeah, you weren't supposed to tell them that.
Well, this is part of here's part of what I want to share. So I wrote back to David. Sorry, David. This is supposed to be a casual conversation. So I wrote back to David and I said, who do you have in mind for annual reports, good annual reports? Because I was kind of racking my brain thinking, well, I know King County does one, but I thought, who else? Well, the ones that pop to mind are everyone in the Council of Ambulance Authorities in Australia and New Zealand. They report all together, same format. Ambulance Victoria, you can find theirs easily on their website, but Council of Ambulance Authorities. So anyway, so that's the one that popped to my mind. But after that, I thought, okay, well, let me do some thinking. I know our friends in Maryland report at a state level. I know our friends in British Columbia report at a province-wide level. I know Everett Fire Department, which is just up the road from Seattle, that they do. But after that, I thought of some as I went along, and I Googled. And I was gonna say, can everybody put in the chat some ideas? Because this is one where I went and Googled, and I had a little bit of a hard time finding EMS annual report 2019 cardiac arrest. That's what I put in. So anyway, I just point this out as something that we say that, is important in terms of that, accountability piece. But I think that this concept can take different forms that might not fit into that, what we traditionally think of as an annual report. For sure, Contra Costa County, of course, is that, this data could be published via annual report within an EMS organization, but it could also be in a separate strategic report. Hilton Head, over on the right coast, has a plan for survival, increasing survival document that they update. This could be, there are lots of communities that share through CARES and just post their CARES data. But this could be a social media thing. I think, number one, we need more of it. And number two, it can take different forms. So that's part one. But David, I know what you asked about a downside. And, that's obviously someone coming back to you and saying, last year you saved 100 people. This year you only saved 80 people. What's wrong with you? And have that be potential, fuel for a fire. King County has started reporting their survival on a rolling average of 5 years, Mickey? 3 or 5 years? Right, and that's to account for the changing numbers in your denominators, because especially for small systems, as we all know, it can be a little nail biting, right? When your denominator is small, you could post awesome, survival rate 70s. I think Joe Penner's group in South Carolina was 100% one year. That is awesome, but there's only one way to go after. I hope not, but
right.
Yeah.
And, a life is a life, and a saved life is to be celebrated, right? But, it's interesting, an anecdote that I'll share very quickly here is that, a few years ago, I was engaging the local newspaper to conduct a series of articles related to sudden cardiac arrest. And the editor of the newspaper happened to be the former communications manager for an area hospital. So I knew he had a taste for healthcare kind of stuff. And I would confidently say I was harassing him via email to yeah, me, to, take this seriously. And he came back to me via email and he said, David, this was probably like in response to my 30th unanswered email to him. And he said, David, I know cardiac arrest is an issue, but hey, I'm in the newspaper store business. Where's the story? And I said,
Mm.
regretfully, it was something to this extent. I said, regretfully, the story is buried in the obituaries,
Mm.
and it needs
Good one.
to come out of the
Good one.
obituaries and be like front page.
Yeah.
So we did agree, and we did do an annual series of about 12 or so articles. And coming back to the question, if we were to give some, again, we're just having a casual conversation with a bunch of people listening in. What do you see as kind of the key attributes of a report card? Because Ambulance Victoria, I mean, that thing's great for somebody as kind of kooky as me, but for John Q. Public, I mean, tell me a little bit more about your thoughts around a scorecard, something that's relatively easy to understand. Share with us some thoughts.
Okay, I'm definitely going to ask Mickey because Mickey is our great fan of infographics. And I think he's actually done this before for the King County report. But I really like the difference that we've seen recently of number of lives saved, right?
Yeah.
So that the Utstein report is important for sure. And those data should still be reported, but this emphasis that I see more on lives saved.
Excellent.
That's what I love to see. But Mickey, I know that you've done some work with King County and their infographic kind of scorecard looking document.
So let me just echo Anne. I agree completely that somehow individuals saved is better than percent saved, because an individual is a walking universe, if you want to be expansive about it. And numbers of people is far more powerful than percent. And the other things that are good to trumpet is the rate of bystander CPR, because that's something that the community is the provider of that care, and so they can be really, really engaged in that. So those are really the key metrics. Now you can talk about response rates, you can talk about levels of care, et cetera, but it really comes down to lives saved and participation in the community. Those are the two most important. I would like to just make another point about this, and that is that measuring your own community is critical. And on the Resuscitation Academy homepage, if you look under, and I hope it's under resources, is the system assessment. And if you just go on that, you meaning anybody who cares about their community could try to answer the questions on that system assessment. And assuming you have the answers to them, like rates of bystander CPR, like number of ventricular fibrillation survivors, et cetera, you can come up with a score. And that score not only gives you your score, but it tells you concrete steps in which you can improve. So I want to just really leave the listeners behind with the system assessment to measure your own community and to see how you're doing.
My bonus, wait, I got to add on to that. The bonus is to do it with your team. Do it with someone if you can get someone from the comm center, someone who knows about bystander CPR, your medical director and EMS chief. I guarantee that it will spark conversations and help really illuminate across the domains things that you didn't know were actually happening, or good or bad. So it really is a great conversation tool.
And David, let me jump in with another comment there. I agree with Ann completely. And another thing to consider doing is to look at it at the micro level. measure the outcome from a cardiac arrest. And this would really be a challenge to do, but is to ask yourself the question, when you encounter somebody who starts in ventricular fibrillation as the rhythm causing the cardiac arrest, and they don't survive, then the obvious question to ask is, why did this patient not survive? Ventricular fibrillation is a treatable cardiac arrhythmia. And if they don't survive, there should be some obvious answers as to why that is. So I think that's almost at the micro level, looking at how has this system failed this person in cardiac arrest owing to ventricular fibrillation.
Yeah, agreed. Time-sensitive, life-threatening emergencies, right? Like anaphylaxis. Anaphylaxis is something that people shouldn't die from. And, if somebody dies from anaphylaxis, from like nut exposure or something in a school, you know that there would be, quite an investigation as to why this occurred, and eliminating every possible reason for its occurrence to make sure that it doesn't happen again. But there's this like odd thing about cardiac arrest where, it's almost like, the Mr. Bean thing. It's like, we don't look, it's, hey, Mr. EMS chief, how's that cardiac arrest survival rate? It's unfortunate, but I think you're right, and I think this brings to point the survivor events and rescuer recognition, right? So typically, if you see a photo from a rescuer recognition thing, it's somebody throwing their arms around somebody, or maybe there's a handful of ambulance people or fire department people. But in reality, when I see one of those, I see the survivor standing there and like over 100 people behind them. The person who advocated for the introduction of CPR curriculum in the schools, amending Good Samaritan laws, the people who actually provide training, the people who sell defibrillators, the school administrator who came up with the plan for the school, all the way through the reperfusionists, the cardiac rehabilitation people, the family, the telecommunicator. It's literally over 100 people. And so, I think that lends itself to kind of a dissection of a cardiac arrest response, and letting people know that, death is not a necessary outcome, and quite honestly, quite contraire, right? Survival from ventricular fibrillation cardiac arrest is entirely survivable, just like somebody who's been stung by a bee or who's had an allergic reaction to peanut butter. Interesting. The two of you have been doing extraordinarily well with the engagement of our online audience today. So, Mickey, being aware of time, and we want to give people an opportunity to level some questions at us, would you mind taking us for a walk through the challenges of leadership, and more specifically, the value of the critical questions that EMS leaders and citizens should be asking? And I'll toggle back and forth between the two different sets of 10, but if you could just speak to the subject in general, that would be fabulous.
Well, the concept of leadership is almost as elusive as the concept of accountability, because It's like we all know when we see a leader, but we don't know really how to define one. And so I'm gonna punt on trying to define what the good EMS leader is, but fall back on 10, the number 10. We only think in terms of 10s, 10 steps, 10 questions, and so on and so forth. But what you see on the screen are really 10 questions we think everyone who is accountable and responsible for an EMS system should be asking. And if the answer is not readily apparent, they should ask, why isn't it available? And what do we have to do to get it? Because measuring your system is the very first step to change. In the academy, we have mantras that we start the academy with. These are pithy expressions that encapsulate a kernel of wisdom. And the very first pithy statement we have, the very first mantra, is measure and improve. And measurement has to be the very first step before improvement can come about. And then it's in a cycle. As you improve, you ask yourself, well, what's the new measurement? And can we make it even better? And you're on this continuous cycle of measuring and improving, and there's no end to it. There's absolutely no end, because you can always get better. But here are 10 steps up on the screen. What is your VF survival rate? What's the bystander CPR rate? We talked about that. Do you have ongoing training and QI for telephone CPR? Now notice how these are all focusing early on with the first step, which is to get CPR started, recognize the cardiac arrest and begin CPR. So then there are the metrics of what's the median call time, what's the median call to start chest compression. Now, there are national standards for this. And in the call to recognize cardiac arrest, a well-performing system can do that in 60 seconds from call pickup time. And the call to first compression time, a well-performing system can do that in 2 minutes. And again, the question becomes, if you're not achieving those times, why? What can you do to make it better? So do we have rapid dispatch? Rapid dispatch can save 30 seconds. And if you believe in the concept that time is survival, if you can shave a mere 30 seconds from getting to that patient with a defibrillator, you can increase your community survival by 5%. Just think, shaving 30 seconds at the front end can increase your survival rate by 5%. What's the time to tone out? Again, another opportunity to get a minute saved. Many communities will have rollout times of about 2 minutes. Can they strive to make that 1 minute? Bingo, another 10% improvement in survival if they can shave a minute. Arrival at the patient site, that's a key indicator, because most EMS programs and fire departments report arrival at the scene. But arrival at the scene is not arrival at the patient side.
Curbside versus patient side, yeah.
And it's often not even the curb. It's like, well, we just turned into the approximate neighborhood. We're at the scene, they report on the radio or key it into their computer. But it's often a couple or more minutes before they actually are at the patient side. Do we have ongoing CPR and documentation? So are you measuring? And are we meeting performance standards? So these are 10 very, very specific questions. And the more you can answer, the better you are in starting the journey to begin improvement.
Right, and as an owner or an accountable leader, you know, I would want to be able to answer these questions, whether I was in an informal setting or a formal setting, right? And you know, to go along with that, you know, 10 questions every citizen should ask, which you know, is, you know, 10 excellent partner questions to the accountable leader flavored questions. And, you know, we should know these things. and we should be measuring them, and we should be transparent with the public and enlist the public's help, because it is a public health issue and requires input from all of us in our own way. It's my personal feeling that, it's my civic duty and moral obligation to know how to do a couple of things that can help save the life of another person in their ultimate time of need, like, pushing on the chest, keeping blood inside the body, right, somehow, being familiar with those epinephrine auto-injectors, and maybe, I know how to squirt some Narcan in somebody's nose if it appears that they're suffering from an overdose. Immediate life-saving care. So I'd like to, I'm looking at the time here, I'd like for the two of you to very briefly give us a couple parting words of wisdom before we go into the Q&A component.
Boy, wisdom is as tough to come by as leadership and accountability. So I'm going to turn to Ann. What's a wise word you'd like to say at this moment, Ann?
My wise word is imagine yourself in the perfect future state. And for me, that's a world where no one dies from cardiac arrest. And that's the place I think we can all get passionate from. And then we just need to start asking ourselves, what would it take for that to be true? A series of those questions to back us up to where we are today. Just continually asking us, what's the next step? And know that you have friends who are here ready to dig in with you and work alongside you shoulder to shoulder.
There is help, right?
There is help.
Help is available, right?
And it could be on the way.
Yeah. So Jennifer, would you be kind enough to let us know if any questions have been asked, and we'll give us our best effort to try to answer them.
Yeah, thanks, David. We do have, we'd had a great discussion in the chat. I see that Paula Link has her hand raised, and Paula, if you unmute yourself, I'll do that for you. You are able to go ahead and talk and ask your question.
Hi, Dr. Eisenberg and Ann. Really nice to hear the discussion today. Why, for so many decades, do you think that there's still too little public awareness about SCA incidence and survival rates?
Since Mickey turfed the last one to me, this one's yours, Mickey.
Yeah, thanks, Ann. Paula, great to hear your voice. Paula is from King County, and she and our team at King County EMS work together doing research projects together, and it was a great partnership, and I miss you, Paula, so great to hear your voice. Well, the question's a great one. How do you energize that question and get it out front? And we all know some of the obvious reasons, but you know, as David just pointed out, it's like a silent disease. It happens in the privacy of people's own homes. There isn't a horrible trauma of an automobile accident or a gunshot wound and death in the neighborhood, which gets front page coverage in the paper. There's rarely front page coverage about an unsuccessful cardiac arrest resuscitation. We're like programmed, that old adage, if it bleeds, it leads, in the media. And that's so true, because there's no blood in a resuscitation. And so it's like it just falls beneath the radar screens. And I don't know how to solve that. I think I'd be interested in any of your thoughts about it. But if we can somehow chip away at that invisible secrecy that surrounds cardiac arrest, it happens, and the immediate people are the family members, and yet it affects a community, just like anybody who just suddenly disappears in a community and no longer exists. There are ripples, but how to make those ripples resonate farther apart so that other people know about it, that is indeed a challenge.
Interesting that you talk about the ripples, Mickey, and there's actually a pretty reasonable ad campaign going on in Rhode Island aimed at drunk driving that's called the ripple effect. And it talks about how so many lives have been affected as a result of one person's bad decision making. So I'm going to noodle that a little bit more. Thanks for bringing that up. Excellent, Paula. Other questions?
Yeah, we have a couple in the chat. Nick Gunderson has asked, have you heard of any role that payers might be playing in driving improvements, particularly under alternative payment models, such as any sort of pay for performance programs related to OHCA performance?
I have not heard of anything like that. I think it's an excellent point you raise. It would be nice to see something like that, or minimal standards that every community has to meet. I know that there is some effort, at least a discussion beginning at an HEW, or HHS, I guess it's called, at the national level, about reimbursement for agencies who respond to cardiac arrest. And there's a fixed fee that the government would pay for responding to that cardiac arrest, regardless of the outcome. And I think that would be an appropriate thing to begin. The EMS system are guardians of health in the community, and so they should be reimbursed every time they send 7 people to the scene to try to bring that person back to life. So it's good to see this dialogue happening, and I think it can only lead to some nice changes.
Yeah, excellent question and idea from Mick Gunderson. Thanks, Mick. Who else is in the lineup for a question?
Yeah, well, Bob Nickerson, excuse me, Bob Niskanen has a really good point. Bob, you're unmuted, or I can unmute you if you'd like to ask about your University of Washington.
Yeah, the question relates to all the statistics and data that we're hearing now every time we turn around on COVID. And it's been fascinating to watch the role that University of Washington modeling group plays. I'm wondering if there's a way to get that group or somebody on that side of the science picture to get engaged in cardiac arrest.
Bob, again, great to hear your voice, Bob. Bob and our team at Seattle and King County also go back many decades. So it's great to hear your voice. Boy, have we spent many hours together in the past. Well, it's a great question. No, to answer your question, we have not approached the group led by Dr. Murray. I remember when he was recruited to the University of Washington, he was considered, boy, this is a great recruit, sort of like a ball team getting a star pitcher. And it was a lot of excitement, but his interest has always been global health. But I think it would be wonderful to try to, I mean, what is a bigger global health problem than sudden cardiac arrest? It's a pretty huge one. So I think it's a great idea. I think we'll put out some feelers and see if there might be an interest on this team.
And here's a fun fact, when we're talking about breaking down silos earlier. As chance would have it, the medical director for our local public health agency and the EMS medical director's offices are next door to one another.
Oh.
Yeah, right. And they've been working hand in hand together since this whole thing started. So I just wonder if some of the work that we're doing around COVID will pay dividends in that we're building relationships we haven't had before, as you suggest, Bob.
Yeah, timing is everything. Speaking of timing, we're coming up on the hour here. And so, as always, for those of you who have been participating in our monthlies for the last several months, know that I always ask for feedback in the end. So using your chat function, give us some feedback on, are these webinars helpful? Is it a good use of your time? Is it an hour that you'll never be able to reclaim? Ideas for future webinars. I've got a couple of really cool ones lined up, but I'm definitely listening to you all because you're doing all the, all the frontline work. So I want to hear, how are these going for you? What do we need to be talking about? Let us know how things are going. So please go ahead and enter that into the chat function. And while you're doing that, we're getting ready to, for the dismount and dismissal. I just, again, want to thank each and every one of you for all the work that you do every day. Your passion, your ongoing and undaunted passion around saving lives. I recognize that. I'm very grateful for you. I also want to extend a heartfelt thanks to Ann and Mickey for taking time out of their busy days to take some time to chat with all of us. Again, not only are they talented, but just really delightful, kind people, and I'm very, very grateful for their sharing time with us today.
Thanks
All
to
right.
Thanks to all you. Great group of people.
Thanks, David.
So with that said, we're right up on the hour. I want to thank you again, and keep an eye out in your inbox. I'll be letting you know shortly what the focus will be for our next month's webinar. And keep up the great work out there. Please, everyone, stay safe, stay healthy. Give me a shout at any time. Look for a follow-up from us all at the Citizen CPR Foundation, and have a fabulous remainder of your day. Thank you.